Hello, everybody, and thank you very much for being with us again. Today, we're going to do something with a bit of a twist for us. We're going to have a recorded session, and at the end, Dr. Woodson is going to join us, and we're going to be, if you have any questions for him, that he will be able to answer these questions. So please use the chat line to answer to ask the questions that you have on your mind for Dr. Woodson, and also if you do raise your hand, I might be able to put you in direct conversation with Dr. Woodson. So again, the beginning, for the first 40 minutes, it's going to be a recorded session of Dr. Woodson talk about the hypoglossal stimulation of the for obstructive sleep apnea. So thank you and enjoy.
This is the greatest invention. I look forward to it. That's all. We've got a little springtime beginning in Wisconsin. It's still not snowing today, so things are turning green. So that's nice.
Is it bad? Is the corona thing bad in Milwaukee?
No, we're not too bad. Not too bad. We kind of flatten it out. Things are under control, but we're just still locked down. So. Resources are quite restricted, especially the high quality masks. So all elective surgery is postponed and clinics are limited. So it's a challenge.
Okay, great. Well, it's great to have you, and I'm going to turn over the podium to you.
Okay, good. So I'll show my screen here. I will see if it. Let me know if it works and doesn't. So let's see. I'm not sure.
It's the green button, share screen.
Yeah, I hit that, and then we'll hit this as the screen I want to square. There we go, and we'll see if this works. There we go. So so that's my screen. Is it sharing with everybody?
Yeah, everything's good.
All right, so it's my pleasure to talk to you about the upper airway stimulation. It's obviously an exciting and fascinating new therapy, but the question is, why in the world do we actually want or need this? Well, we have a great therapy right now for a lot of people, actually nasal CPAP, which just, dilates and stents the airway. And this is an old slide from years ago, but it still applies today, unfortunately. And the problem with CPAP is, although it's uniformly effective in people who use it, if it's not used, it's not very effective. And in this particular study, about half the people either didn't accept the therapy, or if they used it inadequately. So the overall disease burden alleviation, and that's actually how we have to think about this, is disease burden. The disease burden was actually reduced in just a really small group. About 20% had 75% disease burden reduction. It's probably a little bit better now for a lot of groups, but it's still less than ideal. So there's certainly a need for other therapies. The second reason is that even if people use CPAP, and this is actually a study from years ago from Terry Weaver at the University of Pennsylvania in the U.S. They looked at the clinical outcomes compared to how many hours per day on average people used it. And they used different measures. One is FOS2, which is an outcome measure, Epworth Sleepiness Score, which we're all familiar with, and the MSLT, which is an objective measure of sleepiness. And they looked at, well, if you use CPAP more, you saw clinical improvements. And we all kind of know that clinically. But what's notable about this is that when you look, for example, at objective sleepiness, the MSLT, even people that used it more than 7 hours per night, only a relatively small percentage of those people were normalized. And that's even, if you look at the Epworth score, for example, here, if you're using the Epworth and you use CPAP more than 7 hours per night, only, 60-some% had normalization Epworth score. So and we've seen, I think most of us that deal with a lot of apnea patients, realize that there are patients that use the therapy but don't really have the clinical benefit that we'd like. We don't really know why. And sometimes when we do surgery, or use other therapies, people do in fact respond better than they will with CPAP. So there are people who use CPAP and people who don't. Some of the people even use CPAP, though, don't seem to have the benefit we want. So we certainly have needs for other therapies, and surgery is one of those. Boy, if we could just, people come up to me all the time and say, Doc, why don't you just fix it? Can't you just fix the airway? Well, the answer gets to be kind of like with this slide, explains what some of the challenges. We actually do have two really good surgical therapies right now for sleep apnea. We have tracheotomy, which bypasses the airway, and we have maximum mandibular advancement, which skeletally opens up the airway, and for a large percentage of patients, reduces the apnea-hypopnea index to very low numbers. The problem is you're getting this issue of benefit versus harm. So certainly on the sleep apnea point of view, tracheotomy is highly beneficial, but it comes with a lot of harm, a lot of social morbidity, a lot of clinical morbidity. Very few people, unless in the most severe cases, really want to trach. So you have very successful therapy, but unfortunately it has a high degree of morbidity or harm. And so what we really need is therapies with low harm and high benefit. And a lot of the surgical therapies that we have now kind of fit in between things like, let's say, UPPP. Well, there's benefit that's there. But the problem is that for those of us that do a lot of it, realize that, there's a lot of morbidity that goes along with it. So we have a lot of surgical therapies that are somewhat beneficial and in that sense worth doing, but they're balanced by the fact that they have a lot of side effects or too many side effects. And that's one of the problems even in our scientific literature, is that we frequently focus on the benefit of the therapies we apply. So we see something, let's say, like therapies that I developed, like midline gastrectomy or aggressive surgeries like TORS or something. They can show a lot of benefit, but what's not really sometimes shown as equally is the harm or the side effects that go with them. So a lot of these therapies aren't as beneficial as sometimes our data would suggest. So what we need is high benefit, low harm therapies. And that's really where we get into then the idea of nerve stimulation. Instead of trying to do this anatomically, let's treat this as a physiologic problem. And if we can actually increase muscle tone, we tend to not have apnea and snoring when we're awake, right? It's sleep apnea. So if we can actually improve muscle tone during sleep, we can maybe, treat this disease. And there's different ways to treat muscle tone. That's what this slide is dealing with. I mean, there's all sorts of different reflexes, and there's probably other ones that I could go into in greater depth, and I won't. But if you want later, we'll add another hour's talk on it or two and talk about it. I'd love to. But, we could improve the muscle tone and sleep-wake neurons. We can affect negative pressure reflexes. We can change loop gain and respiratory drive. In fact, there are some recent studies coming out where there actually are medications being developed to treat all these. Some of them are showing some benefit. But the idea of the upper airway stimulation is to actually treat the final common pathway, which is for most of these is the hypoglossal nerve, or the nerve that goes to the tongue. And if we can actually stimulate and maintain some tone in that, we can actually theoretically treat the disease effectively. And in fact, when we actually do it, this is some studies from many years ago, just showing that when you stimulate the hypoglossal nerve, well, the airway gets bigger. So you can see here on the baseline on the left side, we have a small airway. These people were both, I think one was actually during sleep and one was awake. But you clearly see in both cases, the airway get bigger. And that's a good thing. And in fact, when this was first developed back in the late 80s, early 90s, at that point in time, a lot of people thought that all the airway obstruction and sleep apnea was due to the tongue falling back. And if you just create the effect that we see right here, boy, you could treat literally everybody with sleep apnea. And as we get on in the next couple of slides, that's obviously not the case, because unfortunately, the majority of people, the primary site of obstruction in sleep apnea is at the palate in the upper part of the throat, not the lower part. But if you look at this slide, actually some of the basic science work done by Olivan years ago as well showed that when you look at something called the critical closing pressure, which is a measure of airway stability, when you go to a basic science lab and you can study the airway collapse, they did see improvements both in the oropharynx, but also in the velopharynx in their closing pressure. So there's evidence even on the basic science side that this could have an effect in more airway segment than just one. And that's what we see here from an anatomic point of view in this slide. And we can actually see here levels of different stimulation with the Inspire implant in. On the upper group of slides is the palatal airway. And in the lower slides is the area of the tongue. And you see as the sensation, as the stimulation goes up in amplitude, well, the airway gets bigger. But the critical thing here is that it not only gets bigger behind the tongue, in fact, I would actually almost argue that the space behind the retrolingual or retroglossal space actually has almost less effect in this particular case than in the palatal airway. And in fact, that's the critical point. In fact, as we go into the airway evaluation for the cranial nerve implants, it's evaluation of the palatal airway and of the upper oropharyngeal airway that's actually really critical to determine the effectiveness of the therapy. But this is the reason why, and this is really kind of a very important slide in understanding how the therapy works. So currently worldwide, there's really only one system that's available. There's multiple other companies working on it. I think within a couple of years there'll be multiple other systems out there. There is actually there's a second system in Europe, although its effectiveness, I'm not sure exactly what it is. You have to ask Joachim Maurer, a few other folks, but unfortunately it's not, I don't think, been as successful as the Inspire. The Inspire basically has 3 parts to it. It's literally built on a Medtronic's pacemaker platform. So if you look at it, it really does the IPG, or the center part is literally a pacemaker. And then there's an electrode that goes up to the hypoglossal nerve. And there's a sense lead that goes and measures the pleural pressure, because there is a timing component involved with this. So the stimulation is not delivered continuously 100% of the time, but is actually timed with ventilation or breathing. The system itself also has different parts to it. There's the implantable part that goes in the patient, but then there's actually the patient gets a little programmer that they can adjust, so they can change the amplitude and they can change, let's say, the delay. There's certain clinical things the patient can change in the home environment, but then there's a much more advanced physician programmer. So when somebody comes into my office and we need to do some advanced programming, we can do that as well. So that's the system. This is the indications currently in the U.S., at least the FDA indications for the procedure. So it's generally indicated for adults with a BMI of less than 32. In Wisconsin, where I live, a BMI of 32 is not a very high number. We see a lot of patients that come to my office that have much higher body mass indexes than that. We do implant people up to BMIs of 35, and actually there's a few people that might have higher BMIs that do better, but certainly the success rate drops off quite significantly as the BMI goes up. I think that's a huge factor. So unfortunately, for the more obese patients, it hasn't worked as well. Severity of disease is probably less important. The index is 64. That was part of the initial trial. But in general, the problem is if you get really high indexes, it's kind of hard for the device to catch up to respond that quickly. So we're not sure. You need a favorable drug-induced sleep endoscopy, or DICE. We exclude what's called complete concentric collapse. I won't talk too much about that. For this talk, with the questions, they'll certainly answer them. It's actually conditionally approved for MRI, and I went years where that was never an issue with any of my patients. And then, over the last 6 months, I probably had a half a dozen patients that have had some pretty serious issues with not being able to get MRI scans, either because of cervical spine disease, certain heart disease conditions. Sometimes they want to get MRIs for AFib to do ablation procedures. We've had a few tumor patients. It's actually, so it is something that you need to seriously talk to your patient about. And I think systems in the future that are MRI compatible will certainly be preferable over those that aren't. The procedure needs to be done under general anesthesia. We've actually gotten it down to about 2 hours for a lot of patients now. We're getting pretty, but the learning curve, it took 40 or 50 to get, faster, and then it goes from there. And then I think there's some global technical issues that we've kind of come across that we found that certain things can be eliminated and just skipped where we didn't have to do it as before. The main reason it needs to be under general anesthesia is the microdissection of the 12th cranial nerve. I think all the other parts, the placement of the actual pulse generator, the placement of the sensory lead could actually all be done under just a max sedation. It's not a really invasive procedure. In fact, that's what's really nice, is that literally even my sick patients, the patients who are elderly, maybe have other medical conditions, I mean, it's an outpatient procedure. They have a general anesthesia. They go home literally with just acetaminophen or Tylenol for postoperative pain. And they have to, a short period of time where they can't do real vigorous physical activities or anything wild and crazy. So I tell them, they can't go out on the golf course for a few weeks. But here in Wisconsin right now, it's a little bit too cold for playing golf, so we're okay in that regard. The procedure, again, it's under general anesthesia. It takes a few hours. That looks like a very similar slide. I think I replaced it. One of the critical issues with the placement is where you put it on the nerve. Initially, we were placing it on a more proximal location, which stimulated several branches of the nerve. The hypoglossal nerve has a medial and a lateral division. And the anatomy there's kind of fascinating. It's part of the challenge. And learning this as a surgeon is to learn this anatomical breakdown of the nerve. The lateral division of the nerve, which goes to the lateral muscles of the tongue, is actually something that those are retrusor muscles. They tend to pull the tongue back. And it's been pretty clearly shown that when you pull the tongue back and do that, it's an unfavorable thing for most people's airways. And so what you want to get is the protrusor muscles that actually physically move the tongue forward. And in doing so, open up the airway and particularly pull on the palate. The second part is actually the placement of the pleural sensing lead. Usually it's in like intercostal space 4 or 5, usually on the right side, so it's away from the heart, so you avoid some of the heart pulsations and cardiovascular artifact there. And on the far right side there, we see kind of a pressure waveform from the sensing lead. And you can actually adjust when the stimulation occurs. And one of the challenges actually with Inspire is the initial, like I say, when they thought it was just the tongue that was the issue, they kind of arranged the stimulation to occur at a certain time in the respiratory cycle, kind of right before, right with inspiration. And we have to actually do some things to try to adjust it so it can actually stimulate more on expiration. And so we've kind of tried to do some things to adjust that. But that's part of the challenge of doing some of the fine adjustments of the stimulation. I think I should be able to get this. I don't know if I can get this to play. This is a relatively short video of the surgical procedure. This is actually, we make kind of an anterior submental incision. I usually look for some wrinkle line or crease, around the hyoid bone, or get that nice shadow line between the submentum and the neck. And this part of this incision has to be extremely cosmetic. And then you go in and you kind of go through the platysmal muscle. I like to use the Lone Stars here. It makes exposure pretty nice and easy. And then you just go down and just find the anterior border of the digastric. I usually use a peanut to do that. And you find the digastric tendon. You put something on the digastric. I think here I'm getting the digastric tendon right there. And I'll actually put a little loop around that and retract it down. It kind of spreads out the submental space. And from there, you can easily see the back end of the mylohyoid muscle. And actually, it's surprising sometimes how close the nerve can be to that back end of the mylohyoid muscle. And so there's some blood vessels, little veins in there. You don't want to go wild and start bipolar cottering back where I'm doing my little dissection here back in the back end of the mylohyoid muscle, because it's surprising how close the nerve can be in there. And then I actually just find the posterior border of the muscle. I just stick a little retractor in there, and you kind of wiggle it in there. I do my little wiggle with the retractor, and you pull forward. And for me, then there's the nerve, and the nerve end tends to be right there. In fact, what you really see initially is the big renin vein. And really the dissection, and I'll just skip ahead here, is really, I tell my trainees, it's really more of a vein dissection than it is a nerve dissection. And I have a name for it. I call it the damn renin vein, because you don't want to make it bleed. But really, it's a matter of getting the vein off the nerve. And there's our nerve right there. You can see a couple different branches there. This where, I don't know if my hand is showing there, my little hand marker, but there's a little break point. And So you get in there and just, dissect out the nerve, and you find the branches that you want. And this is actually a little bit bloodier than average, but usually it's certainly within the realm of the general otolaryngologist to do this. This is not a hugely technical procedure. Put a little vessel loop around there, and then you go in and take your nerve integrity monitor, the NIMS monitor, and go in there. Now we're stimulating the nerves, and we have a recording. You see, we're getting the inclusion versus the exclusion branches, and once we've actually done that, sometime, I don't know if on this week, you can see there a little bit of twitch of the muscle below there. That's the hyoglossus muscle below the nerve right there. And so if you stimulate, sometimes you'll see twitching of that muscle, but you actually do the nerve integrity monitoring. And here you can see there's a little twitch of the muscle when I hit it. And you just dissect that out. Once you've dissected it out, you slip the cuff on. I think that's coming up here quickly. And then you have to, do some work with tunneling the leads to the IPG in the chest wall, and place the chest wall sensor. I think a lot of ENT doctors are more anxious about placing doing the chest wall testing, and that's actually kind of what I was showing there. It's just oftentimes one really small branch that's an exclusion branch that you really need to kind of search out and try to find and get that one last little branch. In fact, you can see inferiorly here, this is probably the branch that goes to the geniohyoid muscle. It's actually not a true part of the hypoglossal nerve. It's part of the C1 branch of but it runs with the hypoglossal nerve, but it goes to the geniohyoid muscle there. And here we're just getting the cuff kind of placed around the nerve, and that's what it looks like when you're all done. We do irrigate it out with a little bit of saline, so you get good conduction. One of the things I do now, actually, Mo Boone from Pennsylvania taught me, is we used to actually, at this point, I would go and do the whole rest of the procedure, and then we would test it out. And by then, you're getting a little bit tired, and so if you didn't have favorable testing at that point, you'd have to then go back and re-explore this area. So now we bring in the IPG. I do the testing right as soon as we put on the cuff on the nerve. I do the testing right there, and if that's favorable, then I don't have to worry about it the rest of the case. And if it's not favorable, I'm right there. Everything's all exposed. I've got my retractors in there, and actually, it saves quite a bit of time and effort to do the testing there. So that's something that I've learned through experience. But there's different ways to it. This is actually a slide showing the effects of stimulation. So this is the drug-induced sleep endoscopy. Oops, let me go back here. I'm sorry. I get it to play. Drug-induced sleep endoscopy without the stimulator on. Here's the tongue base, and you see the airway, obstructed. And then with the therapy on over here, if I get it to play, you can see that with the stimulation, the airway's opening up. I wish to say it was that dramatic in all patients. It's not, but in this patient, it's quite dramatic. But this is what you'd really want to see. Almost looks like this patient, I think, is almost at a palatal pharyngoplasty. The palate looks really pretty short there. But that's theoretically what we're trying to do. I actually do have one theory that actually some of the people that are doing really well with this therapy tend to be the older group of patients with apnea. And those people, they have a general tongue weakness. That the more studies we do on this, we're seeing people have that their tongues are actually too weak. And I wonder that if for some of those patients, this is actually acting as a form of myofunctional therapy, and is actually the therapy is really strengthening the tongue, and it may not actually work just with this mechanism. I'm not saying that this isn't a part of it, but I think in some people there may be actually multiple mechanisms. Now, I don't have any data to support that, but I think that it's possible. This is the STAR trial. We actually enrolled 126 patients, and we were able to follow up 124 of those at 1 year, which is amazing that percentage got followed up. Actually, the one patient actually, unfortunately, died. Actually, they were murdered, and it was one of the patients from Europe. They were hanging around, I guess, with the wrong types of people. And the other patient was one of my patients. One of my patients dropped out at 11 months. He moved to Florida. He moved to a warmer climate, and he kind of refused to do the 12-month follow-up. But all the other patients were followed up, which is amazing, at 1 year. And we were able to follow 97 of them up to 5 years. And of those, a fairly significant number of them continue to get sleep studies. And so I have pretty good 5-year data, for these patients. Major complications were pretty rare, and things like death. Unfortunately, some people did die, but that was non-sleep apnea related issues. A few devices were removed, and a certain number of people were lost to follow-up, as with most studies. And we would expect those were probably more likely to be the failures as well. Baseline characteristics, it was generally a male, a little bit older, middle-aged group that did not have a high body mass index. So this is, I think, still an important point to make here. The sleep study outcomes, a lot of people are familiar with the general data here. Basically, again, people had a fairly high in the severe range AHI. The AHI did not go to zero, but it was reduced. And the point of this slide is that over the 5 years is that there's a group of people that got better and they stayed better. Did it treat everybody? The answer is no. If you look at the distribution of those, the box and whisker graphs there, there are definitely people that didn't respond, but as a group, there's a large group of people who did respond and get better. I don't know if I think this is actually showing the self-reported outcomes. The interesting thing here is the red arrows on both of these. One is showing what's called the FOSQ, which is a quality of life measure. The other is the Epworth score. The FOSQ is improvement is a higher score. Obviously, Epworth improvement is a lower score. But the thing that's notable here, remember that first slide I showed? I don't know what I'm doing here. I think my I don't know, I'm somehow making marks on my screen here, but
yeah, I think somebody else did that on your screen.
Somebody else did. No, that's fine. That's good. Well, then you're, that's fine. No problem.
What you could do is that if you want to take these off, you need to stop sharing and then somebody do again. So if you could stop sharing and then when you share again, there's these 3 dots which says more, and you could disable annotation.
All right, so stop sharing. I'm not sure what you're sharing here. I've lost my, let's see. Yep. We may just, there's stop sharing. Okay, so I've got stop sharing and then go to share screen again. I think I'll just, all right, so we're back to not having any marks. We'll just keep it. So the arrows there show the level of normality of what is normal with these scores. And remember that first slide on CPAP, I mentioned that if you use CPAP for 7 hours per night, only 60% of people had the Epworth score normalized. Whereas with the nerve implant, that number was a lot higher, and it was maintained over the 5 years. So the people that did well with this seem to do really well. And that's, I think, persisted in my hands. The people that have done well have done well. I think that some of the numbers that are being quoted now in some of the studies, I think there's some technical issues with how they're following up. I think that some of the numbers are probably overstated. So there we're getting the marks again, but I'll just keep going. There we go.
I'm sorry, I just had a bit more experience. If you need to stop the marks, you need to, there's the 3 dots with like more.
Okay, it says stop share. Okay, it says stop share.
Okay. Go share again.
Okay, share screen. I'll go to here.
And there's like 3 dots with more. You see 3 dots with more with a menu for the Zoom?
Looking for it, but it's not. There was something earlier, but it's not showing up. Oh, there it is. 3 dots. There we go.
Yeah, push on it. And you will see you could disable the annotation. You could disable. No, not the.
Did you see my
from the baseline
screen? Maybe you push on this. No, but I think this is. No, this is the,
Okay, so go up here. Oh, up here to more. Okay, there you go. Disable participants annotations. Okay, now we're good. All right, so good. Thank you. So another way of looking at the data here is to look at this more like you'd look at a Cox regression analysis like we do for our cancer patients, and that is look at the kind of the successful responder rate over time. And you can see here the same thing with the apnea-hypopnea index, a reduction in the index, and it is maintained. Epworth score similarly, but that's kind of the point is there's a group of people where you see the reduction and it's maintained. I'm not sure on this slides if I put it. The thing that is important is to realize that it's not always the same patient in these groups, though. There's kind of three different groups with the Inspire. There's one group that seems to have a significant disease before Inspire. When you treat them, they do extremely well, and they just do well on every measurement. They just do well and stay well. Every night that they use this, it works. There's one group of people that's the opposite. Okay, they use the device and it's unsuccessful. And then there's a middle group of, probably 40% of the patients where it's kind of variable night to night. Maybe one night it works really well, another night maybe less well, and it's going to vary, within the individuals as to the degree of response, but it's some sort of a partial response, and that's where I get back to where I talked about disease burden reduction. And so rather than centering frequently for me on a single night sleep study, I'm really more interested in how many apneas the patient has over a month than over a single night. And sometimes a single night sleep study may look better than the patient's actually doing, or it may actually look worse. And so I think that as we go forward, I pay a lot more attention to doing like multiple home sleep studies and looking at other outcome metrics than just doing, one sleep study and you're better. Whereas, with the normal surgery, let's say you take out somebody's tonsils, we kind of extrapolate that if we get a single night sleep study, that's going to be reflective of the way you sleep every night of the month or year or during a long period of time. And that's not the case necessarily with Inspire. Inspire, there can be more variability. And so a single night sleep study may not actually really represent the clinical outcome. The one outcome we do know a lot about, and that's adverse events, which were just really infrequent. Serious adverse events, and really most of the serious adverse events had to do with either need to reposition the device and a few people taking it out. They're really, as far as adverse events really related to the device within the STAR trial and even subsequently, it's been really remote. Things like nerve injury, serious infections, other major complications like that have been really infrequent. And actually, I would have thought it would have been higher going into this. But those sort of serious procedure or surgical complications are really quite infrequent. So that, for patients that come in who are potentially candidates for this, and especially now in the COVID-19 world, where some of the other therapies, may be less available just because of concerns about viral spread or things, procedures like this are safe. It may not always be effective, but you can tell patients that it's safe. And this is just going into more specific examples during the STAR trial. And most of the adverse events that were recorded were in the first few months of having the device. And as people went out, 1 year, 2 years, 3 years, 4 years, 5 years, those number of events, really dwindled to being, almost non-existent. So as people go on, they tend to do well. There's multiple post-market studies. I'm not going to obviously go into all of them. I'm going to mention one that's particularly better quality than the others, which is the German post-market study. The company is doing an ADHERE registry. The ADHERE registry, it's got a goal of looking at a large number of patients. I'm not sure that all the data from the ADHERE registry I think is as accurate as some people portray it, but we'll talk about that in a second. All right. This is the German post-market study. This was a 1-year study with patients with severe sleep apnea. And what's unique about this study is they actually did 2 nights of home study without any sort of device manipulation during those nights of assessment. And so these are real numbers. Now, the one thing about the German study, it was a really favorable group. They had a group of people that really weren't overweight and met really the right criteria for this. But it really showed a dramatic improvement. And like I said, those are really solid numbers because it was done on 2 different nights at 12 months. And you see a really clinically meaningful improvement in disease burden. Not zero, but you're getting people to, because mild sleep apnea is not what we're worried about. We're worried about moderate or severe sleep apnea. Mild sleep apnea has not really been associated with major medical comorbidities or risks. So if we can get people into that range, we probably don't necessarily, if they're asymptomatic and in that range and they're happy, then I'm happy. The ADHERE registry, it's mainly, like any registry, is really interested in safety more than outcomes, but they've been looking at it. And one of the challenges at the time that I actually made this slide, about 64% of eligible patients, were participating. And that's a bias. You're saying there's 36% of patients who aren't participating, and you go like, well, why are they not participating? And in my clinical practice, the patients that are happy and doing well tend to want to participate a lot more than those patients that aren't doing quite as well. The other big limitation with this is that they use what's called the titration apnea-hypopnea index. And I've seen even now that in the published studies, people refer to titration AHIs as being treatment AHIs, and they're not. So in a titration AHI, a person comes in for a full night's sleep study. And at some point, at some setting, in some body position, somebody has an index that goes to some low level. And so that number can then be kind of cherry picked out of the air and said, okay, this AHI has been reduced to some number. And they say, well, this is how we do it with nasal CPAP. Well, nasal CPAP's been around for, 30 years. And there's a huge amount of data showing that titration AHIs are valid for nasal CPAP. And I don't believe that titration AHIs are valid for Inspire. There are just too many other things that go on. And I'm, as a sleep doctor who reads these studies on a weekly basis, I don't believe that titration AHIs are accurate. And so we need to really look at, that data that really is meaningful. There are things like the German post-market study where you have some sort of a full night efficacy study. Where somebody's at one setting and you're just letting them sleep as they normally would. I think home studies are ideal for that, but it could be in lab as well. And not all in-lab studies are necessarily invalid, but I think the idea of a titration study being accurate. One study that actually Raj Dedhia, who's and I did, and this was just his personal experience, is that the titration study was showing a 91% success rate when he actually looked at his home sleep studies in the same group of patients. In that group of patients, the titration effectiveness was only 52%. So I think the titration effectiveness really overstates the. Now that's not saying that the therapy is not good. It's just that I think that some of these studies that are kind of suggestive that, boy, if you're not doing nerve implants, the nerve implants are so hugely effective. I think that. So anyway, that's and only a small percentage of the ADHERE registry actually have true treatment AHIs. The literature is quite confusing. The good news is the ADHERE registry is really showing what we're seeing here, which is a very low risk and side effects. I think, though, it's, again, because of the skewed population that it's seeing, some of these are probably understated. And also, I think the questions are asked in such a generic way that it tends to get a more favorable response. A few months ago, I had like 4 or 5 patients we entered into the registry. And unfortunately, 4 of those 5 patients, one that particular month, weren't doing as well as I wanted. They were actually, a couple of them actually weren't even using the therapy because of discomfort issues. And yet when I looked at their ADHERE data, they all looked data-wise as successes. They all had good sleep study numbers. They all had, but 4 of the 5 people were having some issues that I would have considered them to be kind of non-responders. although probably in the ADHERE registry, they probably all 5 look like responders, actually. Just as a catch. So that's part of the clinical challenge as we go forward. But, and this is just showing some of the ADHERE data. Again, the numbers going down to sometimes really very low levels. And that's good. We want people low levels, but I don't want people to feel badly if they say, geez, I'm, using this therapy and my numbers, can't compete with what I'm seeing in the published literature. I think the published literature might be a little biased. The one thing that's really positive about this is snoring outcomes. We've seen about 80% of patients, report a marked improvement in the snoring, where the snoring is reduced to either no snoring or mild snoring. And since that is a major concern of a lot of patients we see, is that that's a good outcome to see. And it also tells me that the therapy is actually having a beneficial effect. That, some of this, a second ago, I was just kind of dinging the titration AHIs. But on the other hand, there's clearly, we're seeing this beneficial effect. And this is going out for 5 years now with the STAR trial. And so we're saying, I say the patients I treat with this can be, quite happy. We're seeing, this is from the ADHERE registry, and they're saying that some of the predictive factors, patients who are older tend to do a little bit better with this. And I wonder if that's because of tongue weakness issues, and that this is being a tongue strengthening device, that it's treating that phenotype better. And again, the people with the lower BMIs, just like all the other therapies that we do for sleep apnea, the skinnier you are, the better you do with some sort of a structural intervention. We do see a lot of people in the ADHERE registry, they're using the device. The number of hours of use is quite high. We don't know how this relates to sleep always. Some of these patients, there's a recent study looking actually at trisomy 21, at Down syndrome, and their average use was like 9 hours per day. And that's because, quite honestly, they're having to use a caregiver to turn the device on and off. And so, yeah, it's not because the trisomy 21 patients are actually sleeping 9 hours per day. I don't know, maybe they are. But I think it has to do with the caregivers are leaving it on for 9 hours per day. So that's the use. So here you're saying really the therapy on, it's not actually the therapy effectiveness or the sleep time. But I think as we go forward, we're going to get better data on this, clearly. One of the challenges with this is how do we look at this, and one of the ways we monitor therapy is by the nature of the tongue protrusion. So there's 3 primary patterns of tongue protrusion. You have bilateral protrusion, where the tongue basically just sticks straight out the mouth. The more we consider, the more favorable, which is a right-based protrusion. So actually the tongue actually extends beyond the teeth and goes to the left. But for some reason, we decided to call that right-based protrusion. And then this what we call mixed activation, where you get some sort of retrusion of the tongue. So the tongue may flatten and pull back. Part of the tongue may move forward, part of the tongue may move back, may rotate to the right. You'll see different patterns. And in general, the right-based protrusion is the more favorable outcome. You get better clinical outcomes with that. Bilateral protrusion is okay, but the mixed activation, although the effectiveness is not zero, it is significantly diminished. And so there is some data out there, and we're trying to work on this as time goes on, that if you change the electrode configuration, you can actually change sometimes the phenotypes of tongue movement. It's not as clear as we'd like it to be, and it's kind of arbitrary, but that's part of the challenge as you go forward. We'll have people that may not be doing as well with therapy, and we'll work on trying to change the tongue protrusion to try to get the airway to open up more. The other way to deal with failures is to add additional surgeries on. This is a study, again, out of Germany, where they had a group of people that between 1 and 2 years were not successful, and they did additional palate and tonsil surgery and converted a number of those people to being more successful. So that's another option to deal with failures, is to add additional surgery on there. The challenge going forward also with COVID is that we've used part of the way we actually isolate people and try to determine favorable candidates is to use drug-induced sleep endoscopy. And at least here in the U.S. Going forward, we honestly don't know when we'll actually really be able to start doing that again, since we're now considering laryngoscopy to be a potentially aerosolizing procedure. And for us, the issue is the lack of PPE material that and questions as to how long operating rooms have to be left empty if you're doing an aerosolizing type of procedure. And given the nature of drug-induced sleep endoscopy, you have to really question whether it's valuable enough to use up that degree of resources at this point in time. And so the question is can we do things like this? Is a study from Rich Schwab from a few years ago where they're actually trying to use CT scan actually to look at responders versus non-responders. But maybe this is the future for upper airway stimulation is to do some sort of a more dynamic CT scan or some other evaluation. This was actually done with people that were implanted, and they were looking at people with and without stimulation, and they were able to identify some characteristics that predicted favorable outcomes. But maybe this is the future where we need to go. And this is obviously an extremely small study, but it's a challenge going forward. So, so far today I covered that that upper airway stimulation does determine long-term improvements. Certainly in AHI and ODI and some self-reported outcomes. There's a very low incidence of adverse events. The challenges going forward is really lacking much in the way of what I'd call clinically relevant outcomes, things like blood pressure, objective sleepiness, issues of heart and metabolic disease. And those are even big challenges with nasal CPAP. I was just last week reading a big meta-analysis of CPAP therapy, and the result of the meta-analysis of CPAP therapy across the board is actually showing much less in the way of effectiveness on clinically relevant outcomes. And I think the future of any sort of therapies that we apply to sleep apnea really needs to look at which subgroups we really need to treat. I mean, should we be using cranial nerve implant if the main metric that we're looking for is snoring? And the answer, probably from a health system point of view, is probably no, that this is too expensive a therapy to be applying if the only outcome you're treating is snoring. But I mean, that's something that we have to discuss and decide. We may decide that is actually adequate, that if you can put an implant in and it treats somebody snoring for the next 60 years, maybe it is worthwhile to do. And especially as new therapies come out that maybe are less expensive, I would see that there's going to be a real drive to developing methods to do upper airway stimulation that's less invasive, that's less costly, more accessible to more people. I would say that with the current therapy, with the Inspire, that the surgical procedure is really just a modification of what we all do, that any adequately trained otolaryngologist with a little additional anatomical training should be able to basically do this as far as a procedure goes. I think the biggest challenge going forward is integrating the procedure with all the other sleep care. I mean, that's the hard part, is dealing with the patient's insomnia, dealing with all the other clinical aspects of the sleep medicine challenge. I think is greater almost than the surgical challenge. The surgical technical part of this is not the hard part. It's kind of like a tracheotomy in that sense, right? The technically doing the trach for most patients is the straightforward part. Taking care of the tracheotomy long term is the hard part, and that's kind of, I'd say, what I'm seeing with upper airway stimulation. We used to, at one point in time, we thought that we could hand that off to our sleep medicine colleagues, but they're not. A lot of these doctors are respiratory doctors, and dealing with an anatomic and a neurologic therapy like this has not been easy for them either. And so I think that that has to be worked out as we go forward. So I think that's my last slide. And
It's great. Thank you very
Good.
much. A great lecture. We really enjoyed it.
good.
So I'm gonna. We have a few questions for you, and first to go is Dr. Yusuf. Can you hear me?
Yeah, I can hear you, Maz. Yeah.
Hi.
Hi, Dr. Woodson. This is Dr. Yusuf. I'm from Manchester, England. Thanks for your excellent talk. My question is regarding the selection of your patients when you have done a DICE or whatever pre-op sleep study, and when you notice a multi-level obstruction at the palate as well as the tongue base. How do you decide when to do this procedure? Or do you do the palate and the hypoglossal together, or you do palate procedure first and then wait? How do you decide on this multi-level obstruction?
Great question. So for most people most people are seeking out this device as a single treatment. So we're usually not doing this planning it necessarily in combination with other therapies. Right now,
Hello, Tucker.
Hello. Yeah. Hi.
Hi, Tucker. How you doing? Thank you.
Good.
Thank you very much for joining us. We're trying to be creative here and try to use the recorded because I felt that your talk was really interesting. I felt that I would wanna run it by the audience again.
Okay.
Yeah, can I ask you to take a look at the chat lines? There's maybe like 2 or 3 questions.
Okay. Yeah. Sure. If I can find them, so chat.
It's next to the share screen. There's a chat.
Yeah. It's yes, I've got it.
We have some complaints
Yes,
about the quality of the.
I see that the participants. I'm on the chat. I see the chat. I'm sorry. Maybe. I'll try.
Well, I could read it for you.
Okay, go ahead and read it. Yeah, test. I'll test.
Yeah, do you ever do bilateral stuff? Do you ever bilateral implants?
Currently, there's a company working on a bilateral implant. The Inspire right now is not designed for bilateral, but there's a company called Nixoa that's, I believe it's actually, it may be CE mark approved, so they may be doing some in Europe. They did the initial trials in Australia. Success rate seems to be right now very similar to Inspire. We're hoping they'd be better. I think that the challenge is some of the technical issues. Currently, although it's a bilateral implant, the stimulators are actually, it's attached to a single source, so you can't independently stimulate each side. So if, let's say, one electrode has a higher impedance than the other electrode, then actually gets less stimulation. And so there's some details to work out. But yes, the idea of the concept of bilateral stimulation is that it would be more effective than at least based on our current understanding of the mechanism. So that's a great question. Yeah.
So do you see the other question is that is there a strengthening effect of the continuous use of the device on the muscles?
I believe yes. I believe that's the answer is yes. In fact, I think that's how some of the people respond, that it's actually not so much the breath by breath stimulation, but it is the continuous strengthening of the muscle. So it acts as a kind of a physical therapy device, actually. And for some people, I don't have data to support that, but based on, when I look at sleep studies, you see people that it seems to be that they're just better. It's not so much that the stimulation breath by breath is getting rid of the apnea. They just don't have apnea anymore. And I think it is the stimulation. Yeah. So another great question.
Do you think, like, realistically you could run a surgical sleep apnea practice without considering these devices?
It's certainly in my practice, it's becoming a bigger part of the practice, but I think we're still waiting to be seen. I think it's still, we're seeing new and better, soft tissue and other approaches. The thing I really like about having Inspire available to me is that it's not necessarily more effective than some of our other, ENT surgical therapies, but it's certainly a lot less invasive. You don't have the so many of the other surgeries we have, unfortunately, were kind of like you were, back when I was in training and sinus work, we had things like, Caldwell Luck, we had, external ethmoidectomies, we had, frontal osteoplastic flaps, and, our results weren't very good, and we had a lot of complications. People had a lot of side effects from the surgery. And I think in sleep surgery, we're still basically in the 1970s and 80s where sinus surgery was. And the Inspire allows us to offer a less invasive approach that doesn't have the side effects. I think that's really, and
What's the
so
what's the total number of implanted devices in the world? Do you have a guess on that, or do you have
I would guess it's probably, I know that at last count, which was probably almost a year ago, was over 5,000, 5 or 6,000. So I'm guessing it's probably in the 10,000 range now. I think they're really trying to ramp it up. That's a guess. So it's somewhere in the range of 5 to 10,000, I believe. So it's still a small number, compared to the global number of sleep apnea patients. But
one last question: do people with high tongue base collapse respond better to upper airway stimulation?
I think so. I think that, if you have isolated tongue-based obstruction, they do better. There's a device that's also approved in Europe called Imthera that works in a little bit different mechanism. And they had really good success rates in people that had isolated tongue obstruction. So I think those people that have isolated tongue obstruction do better. Yeah, but the failure is frequently at the level of the palate. That's still the issue. And some of the recent data, and it's not, it's been submitted for publication, but it suggests that some of the other findings on DICE, that's not the complete concentric collapse, but there are some other findings on DICE that do predict outcomes, and that should be hopefully published soon.
All right, great. Thank you again for taking these 10 minutes. I really appreciate it. You were exercising.
Pleasure.
Were you working out? You look like you were.
I was earlier. Yeah, I was working out. I was working out. We're actually going up. We live on a big lake. Lake Michigan is a very large lake. It's several hundred miles in size. We're taking a day trip to go up to the beach farther up. Although it's very cold here. It's about 15 degrees and windy, so it's no swimming. But we're gonna go enjoy the beach.
Okay, great. Thank you, Tucker. Thank you again. I really appreciate this. Thank you. Take care. Bye.
Have a good day.
Thank
Evening.
you. Thank you. Take care. Bye. So basically, I mean, what I was trying to do here is really trying to be a bit creative in using the generosity of the people who contributed to this. But like you could please, I really would like you to download the app. It really gives us a great way of communicating. Basically, you could tell me what's on your mind. You could tell me things that are working, things that are not working, how to improve the program. Would like to be in this as a group. So please, download the app, and thank you again for being with us, and have a nice evening, and take care.